who is an associate professor of GI oncology at Roswell Park Cancer Institute. And she will present her oral abstract entitled Gemcitabine, Capecitabine, and Bevacizumab in patients with advanced biliary cancer, the final results of a multi-center phase 2 study.
Thank you, Milind and Nabil, for the invitation. I feel no pressure presenting after 3 Lifetime Achievement Award type presentations. The study was supported by an investigator-initiated grant from Genentech. I have no conflicts of interest. One other disclosure, I won't talk about genes. The background when we started this study in 2008, 2009 was that we knew gemcitabine-based doublets are effective and were standard, even though we didn't have ABCO2 data at that time. Our own data, gemcitabine and capecitabine combination, based on the phase 2 recommended dose by Hess et al., had shown that this regimen is active. And across the border at the same time, Jennifer Knox in Princess Margaret Hospital had done the same study as us, and she had a much better data, bigger trial, a bit bigger sample size, and found PFS of 7 months. So at the same time, as this study was being designed, Milind was at Roswell and had just done a study of gemcitabine, capecitabine, and bevacizumab. And since VEGF is overexpressed in biliary cancers, and investigators had shown that it does have some prognostic value, we thought that adding bevacizumab to what was then our current institutional standard would be worth investigating further. And there wasn't much preclinical rationale for this combination. As you know, there are limited preclinical models available to do this work. So we did this single-arm, open-label phase 2 study at Roswell Park in Ohio State Hospital. The key eligibility criteria are listed here. Stage 3 or 4 patients were included. Ampullary patients were not included. Performance status 0 and 1 were inclusion criteria. Prior therapy was allowed as long as it was adjuvant. Our primary endpoint was to assess the progression-free survival of this regimen and compare it to the retrospective data that we had. And the secondary endpoints were to look at response, toxicity, overall survival. And as a correlative endpoint, we wanted to know the impact this therapy had, given that the bevacizumab toxicities would add potentially some impairment in quality of life, what the actual impact was. We had also done some work with circulating tumor cells in biliary cancer patients and found that they can be found and detected in peripheral blood, and we're looking for biomarkers and decided to look at that as well. This was the treatment plan. Gemcitabine and capecitabine were given at these doses, along with bevacizumab at 15 milligrams per kilo Q21 days, based on the work, based on the doses that Milind had selected when he did the pancreas trial, and we assessed response after every 3 cycles, which is about 8 to 9 weeks. CTCs and quality of life were also assessed at baseline and then after each cycle. Response was assessed by RECIST, and we have an independent response review committee at each institute that confirmed our responses. These are the results. 50 patients were accrued over 2.5 years, beginning at the end of December 2009. Median age was 63 years, 52% were male, and 94% had metastatic disease. The distribution between extrahepatic gallbladder and intrahepatic cholangiocarcinoma were respectively 20, 22%, and 58%. And for those of you that are interested in gender disparity and accrual of minorities in clinical trials, there was a paper in JCO recently that about 2% participation by minorities occurs in most clinical trials, and here it was about 10%, and that's something to keep in mind as we do research moving forward in this population. Median progression-free survival was 8.1 months, and just to refresh memory, GEM-CAPE alone in the Jennifer study was 7 months. Median progression-free survival for the different subgroups of biliary cancer were 7.8, 7.5, and 9.2 months respectively. As expected, intrahepatic patients do a little bit better. Overall survival for all patients was 11.3 months. 1-year survival rate was 0.47. And overall survivals, we generally expect gallbladder patients to do a little bit worse, but in our population, in this group, they seemed to do slightly better than the intrahepatic cholangios. Median number of cycles was 8. Median treatment duration was 5.8 months. Response was seen in 24% of patients and stable disease in 48, with clinical benefit in 72% of patients. And those who were responding stayed on therapy for close to 9 months. Toxicities were seen in a lot of patients, hematologic being the most common, followed by GI, nausea, vomiting, elevated liver functions. Infectious complications, most of which were biliary sepsis, and a couple of patients with pneumonia and other cellulitis and other infections were also common. Given that these patients were on bevacizumab, thromboembolic complications, pulmonary emboli, and DVTs were also seen, which can occur, of course, with this population as well. Rare but serious side effects, hemolytic uremic syndrome, acute renal failure, and a GI bleed were also seen. Reasons for coming off therapy, however, despite all these toxicities, for toxicity was only 10%, progression 64%, death 4%, and other reasons 22, most of which were clinical deterioration. We looked at quality of life using the FACT-HEP score, and in our previous GEMCAPE study, we had seen that patients who were responding, getting benefit radiographically, were also reporting stable or improved quality of life scores, and those who were not responding started reporting scores that were suggestive of worsening quality of life as expected. And since in our pancreas trial with performance status 0 and 1 patients who we expect to do really well, we generally think of them as folks that will have a median survival of more than 6 months, we actually looked to see what the quality of life score was after 1 and 2 cycles of therapy and found that that was predictive of, or was able to correlate survival greater than or less than 6 months, which happens to be a benchmark for pancreas cancer anyway. So we looked to see what happened with these patients, and with responding patients did report improving quality of life. And in addition, what we found was that once we assessed what the baseline score median was for the entire cohort, an improvement or a score above median after 1 and 2 cycles of therapy correlated with better survival of 13 compared to 9 months for those that didn't report improvement after 1 and 2 cycles. And we thought this is something that can be used moving forward. We looked at this in our pancreas trial and saw this to be true, and then now we've looked at it here prospectively, and once again that seems to hold out. Circulating tumor cells, the reason why we looked at this is that there is a validated assay, as you know, using the Veridex kit. Cell Search is the name of the assay that looks at circulating cells that basically express EpCAM and cytokeratins 8, 18, and 19. EpCAM is overexpressed in gallbladder cancer and cholangiocarcinoma. Different reports have given ranges of what they have seen. And we had looked at circulating tumor cells in a group of biliary patients, not all of which were stage 3 and 4, and some of them were on treatment. And despite all of those caveats, in this small study, we found about 42% of patients with biliary cancers actually had detectable circulating tumor cells. So in this study, we did have the CTC assay performed in patients at both sites. 4 patients, unfortunately, didn't get their samples done right. Lesson for those of us that want to do correlative work in setting up the assays and systems to collect samples in everyone. But median overall survival in the 21 patients who actually had detectable circulating tumor cells was 9.4 months, and was a lot higher, 13.7 months, in the patients who actually did not have any detectable CTCs at baseline. So in conclusion, median progression-free survival of 8.1 months and overall survival of 11.3 months with GemCape and bevacizumab is very comparable to what the current standard regimen, gemcitabine and cisplatin, is. Based on prior studies of GemCape alone, PFS 7 months, and bevacizumab and erlotinib, which is about 4.4 months, bevacizumab does appear to have some modest additional effect, but this study is really limited by its non-randomized nature to really say that with confidence. Despite a lot of grade 3 and 4 toxicities, only 10% of patients came off due to toxicity, which is something important to note. The fact that we were able to detect CTCs in this trial, as far as I know, this is the first time we're reporting prospectively looking at CTCs in this disease population, and using a validated commercial assay that others can use as well is valuable. And the number appears to be 46% of patients have detectable CTCs at baseline, which is also some additional knowledge added to what we already know. And the lack of detectable CTCs and higher than median quality of life score are simple assays that we can all use, and perhaps since we have seen some value here, incorporating them and looking at their biomarker value in future studies is warranted. So future direction, putting this in perspective, when we did this study, we didn't know that ABCO2 would come and change the whole landscape. At the time, gemcitabine was really it, and this study would have looked really good. But now that we have GemCis, I think keeping this as well as the BT22 study in mind, putting it all together, our current standard is a median survival of about 8 months. And even though in the BT22 study they did report a PFS of 5.8 months, I think you can attribute it to the fact that they were doing response assessments a little more frequently because their overall survival was identical. And the inclusion of ampullary patients, which I know in your meta-analysis you reported, Dr. Valle, that the ampullary and performance status 2 patients don't seem to be benefiting from GemCis as much. They still benefit, but not as much as the performance status 0 and 1 patients. So I would conclude moving forward that there is some modest activity that anti-angiogenics do have, and even though the ABCO3 study was negative, there were some very substantial responses seen in the GemCis combination arm with cediranib, and also a trend towards overall survival. So there is some activity, but perhaps like in colon cancer, we really have to improve these patients' survival and find a really good backbone before we can measure some meaningful improvement that anti-angiogenics can add. The study design that we used here is something that I know many other investigators are also looking into. The PS0 and 1 patients are really healthier, fitter for some of these combinations, and perhaps the ones that we should include when we look at combinations like the French did for the FOLFIRINOX population, FOLFIRINOX study. And CTCs and QOL are things that we all know are important endpoints and should continue to be looked into. And with this, I would like to thank everyone. I always make my acknowledgement slide first and then fill in the blanks. I want to thank all the hardworking research teams at Roswell and Ohio State, all the referring physicians. We had a patient who came and was on study for a year and a half all the way from Connecticut, and my mentors, all the patients and their families, and wanted to specifically point out this is Heidi's husband. He was on this study, and I'm grateful that she's here and you're seeing these results before anybody else. Thank you.
Thank you, Renuka. Any questions?
It's dinner time.
Go ahead, one. Sorry.
Thank you very much. Thank you. I guess you'd expect me to comment. First, a quick question about the capecitabine. So one of the concerns we've had about capecitabine is the relatively high incidence of high bilirubin, which can then, in a cholangio population, send you down the wrong avenues of investigating biliary drainage and so on. So were you able to identify that as a problem in the study? And the second question is, based on the results of your study, where next?
Well, after everything that you did, it became a little hard to do anything next. Jennifer was hoping to do, she had approval from Roche and NCI, as you know, to do Gemzaloda versus Gem, but then after your study came out, that sort of was no longer being developed. But coming back to whether GemCape is even a backbone, I think it still is an active regimen, and we do use it in a lot of patients. Sometimes there's a reason to not be able to give cisplatin. But I think 2 reasons. One that you stated with the bilirubin, And at least in the US, we run into a lot of problems. I don't know about other investigators with oral prescription medication coverage problems. So realistically, to get this to move further and make that the backbone and move further, there doesn't seem like we would get a lot out of that. But I think in the second line settings, this is something that we could definitely be looking into.
So one, with due respect to you and John, one of the problems with prolonged Gemcis is often the creatinine clearance changes by the time you're on month number 6. And for instance, we have an FGFR study. Those mutations and fusions are not easy to find, but when you find them, you get out of the window because you are falling below the creatinine clearance or something like that. So sometimes I think there are issues with both regimens, really. Yeah. Yes.
Looking back at what you've done with these couple years with the 2 institutions and enrolling patients in a single-arm study without concomitant controls, do you think that the effort was worth the information that you gained? Is it really, should we be doing randomized phase 2 in this situation as opposed to a phase 2 without controls? I can't really see that this puts us any closer to anything that's useful.
Absolutely. I think now that we've learned that we can actually accrue these many patients, even to design a 50-patient biliary study, we were pretty shocked and proud of ourselves that we were able to finish it in 2 years. And now that we know we can do it and we have this forum and opportunities, we definitely need to be doing more 100-patient randomized studies.
But I would also, on the flip side, argue that she very elegantly showed that at the completion of this study, this is not a signal to go forward to a phase 3 randomized large study of 300 patients. So there was also some lack of unnecessary use of resources, and this small study did answer some question that didn't need a huge study to answer. Thanks very much, Renuka. So the hour is late, and we are a little bit behind for dinner. Stacy?
So dinner is going to